Good evening, everybody, and welcome to the 51st episode of In Conversation live from the Royal Society of Medicine. I'm Roger Kirby, and I'm pleased to say that your generous donations, which we always ask you for at the end of these programs, have now amounted to £153,000. Now, that sounds a lot, but actually we've got a deficit of £4.5 million because of the pandemic. But it does help. It really, really helps. Well, this evening, I'm absolutely delighted to say that we have Dame Lesley Fallowfield, DBE, who I met some time ago when she gave a talk to me and a group of urologists in Dublin about communicating bad news to patients with cancer. So, Lesley, you are most welcome. I'm just going to give a little background for you, about you, because I think it helps people when they're formulating their questions, and we do welcome your questions. So Lesley Fallowfield is a British cancer psychologist and Professor of Psycho-Oncology at the University of Sussex, and the main outcomes of her research have been the establishment of assessment tools to measure quality of life in clinical trials of cancer patients, and the design of educational programs to improve oncologists' communication, not just oncologists' communication, but all doctors' communication with their patients. And I won't read the rest because we'll come on to that in our conversation, but notably she was made Dame Commander of the British Empire in 2016, and I'll be asking her just how proud she was when that came through later on. But Lesley, let's start at the beginning, because this is a bit like Desert Island Discs without the music, and we'd love to hear some background from you about your childhood and what happened to you and how you got into the profession you're in now.
Okay, well, hello, Roger, and hello, everybody who hasn't got anything better to do than listen to me talking. My background, well, it was pretty unimpressive, really. I came from a fairly modest background. My father was a builder, so I can fix things. My mother was a typical mother. I had one younger sister, and we grew up for the first 11 years of my life in London, street kids really, and then moved down to the wonderful county of Dorset, where I just loved it. I mean, I enjoyed school, I enjoyed the beach, I enjoyed everything about it, although my father was quite authoritarian, and don't forget we're in the 60s here where things were really loosening up everywhere. And so I guess I'd had sort of aspirations at one stage to do medicine, although I found an essay that I wrote when I was 11 that suggested I wanted to be a vet, which makes all of my family laugh, given I couldn't put drops in my cat's ear at one stage. But anyway, I was always attracted to science. I really didn't do well at physics though, and in the late 60s, to gain entry to medical school, you had to have A-level physics. And I rather despondently just left school after the first year in the sixth form. I didn't even take A-levels. And I worked in Germany for a bit in youth hostels, came back and thought, what have I done? And went to do nursing at Guy's. And it was a great time to be in London, 1968, lots happening. I loved actually being at Guy's. The nursing sort of hierarchy was probably not to somebody of my disposition always. But quickly, I think, whilst I was there and doing my nursing, I did realise that perhaps I'd undersold myself a bit, and I still had a sort of interest in medicine. I loved going on the old-fashioned ward rounds and listening to the medical students struggling to answer questions that I thought I knew the answer of. Anyhow, so that was my early life, really.
And tell us a little bit about how many years did you do as a nurse there? And Those, of course, will be the days where nursing uniforms are absolutely pressed and nice little hat, and the wards were spotlessly clean, and
Absolutely.
and the surgeons were probably quite scary. What sort of ward did you work on it, guys?
Okay, when I sort of qualified, I worked on a male medical ward. It was run by, well, the three consultants that worked there were Houston, Joyner and Trounce, and that used to be the Bible in terms of the textbook of medicine that all medical students had then. And essentially, I was interested in hearts and lungs, and we had an oncologist called, well, a physician called Bob Knight, who worked on that ward as well, who had just started giving chemotherapy to lung cancer patients. But hearts and lungs were really sort of what interested me most of all. And I did work on intensive care as well and coronary care. But I then married very young, a dentist, and we moved down to Brighton. I carried on working on intensive care at the Royal Sussex County Hospital. Got pregnant, and whilst I was sort of having my first child, I thought that I probably ought to do something with my brain. So I enrolled on the first courses that the Harold Wilson and Jenny Lee had just started, the Open University, the University of the Air. I did hundreds of different courses, anything and everything, just to keep my brain going. That included logic and philosophy, art history. I did a course in genes and development, and I came across psychology, but more the neuroscience side of it. And here comes the educating Rita bit of the story, because my then tutor said, look, what on earth are you doing? You're doing all these courses. You need to really work in this area. Come to Sussex as a mature student. You will get exemption from half the course, do a BSc in experimental psychology and neuroscience, and I see a good future for you. So indeed, that's what I did. And I won an MRC fellowship to do a PhD there. And I did a PhD in ways to measure the integrity of the optic nerve in patients suffering from demyelinating disorders like MS. Remember, these are pre-MRI days, and in that era, you really waited for lots of different sensory systems to start failing before you diagnosed MS. And an early sign of it was often optic neuritis. And when patients actually recovered their vision, they would still complain of colours looking washed out or not being able to see very clearly, despite going down to the bottom line on a Snellen chart or passing Ishihara colour tests. So what I did was, and I had to do part of that for a year in Cambridge, was develop some ways to measure these perceptual difficulties that patients were experiencing, and the things that people thought you couldn't measure. And that actually has stood me in great place for everything that I've gone on to do subsequently.
Why did you have to do the 6 months in Cambridge? Could the laboratory work, or?
Oh, yes. I got a fellowship up there from Lucy Cavendish College and worked on Downing site in the Craig laboratory, because they had some very sophisticated equipment there. Mm-hmm. It took me actually 6 weeks just to build my equipment. Right. And I got patients from Addenbrooke's to join in the studies. So so my career was going sort of really quite well. I was, looking to be a visual scientist, really. But then something quite awful happened, really. I'd lost my husband by this stage, who had married a nice little nurse and didn't actually quite like the idea that I was now sort of aspiring to be an academic. And I had 2 small children, and my closest friend, who used to help me when I was doing my studies, share the school run and that sort of thing. She developed acute myeloid leukemia, and she died in the Royal Marsden of rather horribly of graft versus host disease. And when I last saw her, and it's pretty horrible to see somebody in that condition, let alone somebody that you care hugely about. And she looked up at me, she was really close to death at this stage, and she said, "You're meant to be so clever. Why don't you measure or do something more important than just these eyes?" And I said, "Well, I don't really understand what you mean." And she said, "Well, why people do things like this to you and not tell you what might happen?" And it really sort of affected me quite dramatically. I still know the car parking bay at the Royal Marsden in Sutton, where I sat and cried for about an hour. And she did die then, she was only 32. And about 2 weeks later, I read an article in one of the Sunday supplements, and it was about a surgeon who will be very familiar to RSM members, Michael Baum. And it was about him and his two brothers and all the wonderful things they were doing. But there was one quote from Mike that said he thought that the psychological aspects of breast cancer were poorly understood. So I phoned up, sent my CV, and said, I want to come and do some research. So that was the start of something quite dramatic.
And did you actually go and visit him? Did you go and see him in his office?
Yes, I did. It was all, I mean, I'm, you know, one of the things I'm so grateful to my rather authoritarian father for is the fact that men who are quite impressive don't scare me. But I walked into Mike's office and he looked at my CV and he said, "Well, what are you doing here? You know, sort of, this all looks quite impressive. It's got nothing to do with breast cancer." And I said, "No, but I want to work in cancer because my friend has just died, well, of leukemia actually, but not breast cancer. But, you know, can you give me a job? I want to make a difference." And he said, "Well, look, you know, you go and get some counselling or something. You know, it's an impressive CV, but really sort of, you know, I don't think you're quite the right person." And he'd started actually almost reading something else. And I got to the door and I turned around and I said, "Professor Baum, I know you think I've wasted your time, but I will find someone somewhere to give me a job. I am going to make a difference. And I know how to measure difficult things. I know how to measure things that people say you can't measure. So give me a job. I want to measure the quality of life in patients with breast cancer. And, you know, I really want to do this." And he frowned a bit, but then called me later and said that he couldn't stop thinking about the conversation and gave me a job. So I did the first study I did with him at King's. It was the Cancer Research Campaign Clinical Trial Centre. He had just launched a study comparing mastectomy with breast conserving surgery. And I was to measure the psychological impact of, you know, both treatments. So that was the start, and I've never looked back since. So I'm really grateful to Mike, because there were lots of things that he taught me that I think have really stood me in good stead. One was that you should never be scared to challenge orthodoxy, number one, or stick your head above the parapet, provided you've got data. So I think I've always remembered that. And the other thing he told me when I gave my first talk to the department there was, look, you know, if you want doctors to listen to all the things you've got to say, you need to enter their world, learn their language, learn the language of cancer, learn oncology, and then people might listen to you, because at the moment you're just talking about theories and ideas and concepts that nobody particularly understands. So that was good advice as well. So I owe him a lot.
A couple of comments and questions coming in. The two friends of yours, David Jones, he's a urologist out in Gloucester. He says, say hi to Leslie, who was a staff nurse at Guy's when I was a medical student and kindly came to Gloucester to give a talk on communication. So hi, and hi from Phyllis Olden. She says you're looking great, and she wanted to send good wishes. And then there's a question related to what you just said from Mariana Taberner. Thank you, Mariana. How did you know that you were good at measuring something that's difficult to measure? That's quite a good question.
Well, because of my sort of PhD thesis, because as I said, these patients with MS, after they'd recovered from their optic neuritis, they had very clear perceptual problems that they were reporting, but conventional clinical tests couldn't pick them up. So I spent a lot of time with my visual science colleagues and neuroscientists actually trying to work out what was going on and how we could actually measure it. And indeed, the equipment, I told you that I spent 6 weeks with colleagues up in Cambridge sort of designing this incredible sort of equipment to measure particularly the color deficits that they had. A lot of the tests that I developed in my thesis were then taken up by engineers and others to, I had great big computers and filters and lenses all over the place. They manage, it's now a little chip, some of the sorts of tests that I actually originally designed. It's a chip in something.
Mm-hmm. So the metrics of quality of life, just let's go on then to talk about how you started off on that. I mean, nowadays, quality of life is, they incorporate that in so many studies, and that it's very important for drug companies because of NICE and so on and so forth. But you were one of the first people into it. So tell us how you set about working out how to do it.
Okay, well, sort of when I started working on that original trial, clinical trial with Mike, really sort of quality of life was sort of probably limited to just measuring psychological and social problems that patients were experiencing. There were a few pioneers who were trying to encourage people to measure what we now call patient-reported outcomes in terms of symptoms. But they're really, the field was really open to develop some better measures. The other problem, of course, is that people couldn't really define quality of life. They used to think of it as a rather woolly concept. I mean, everybody had a different definition. And until you can define something properly, you can't actually measure it. So we did set about using some really quite sophisticated techniques of psychometrics in designing the types of questions that would give you more insight into patients' perceptions of their physical, functional, social, and emotional functioning when they were undergoing different procedures or different treatments. And this has, I really value my collaboration with a wonderful, wonderful man in Chicago called David Seller, who I've worked with closely for, it must be 40 years now, on development of and validated instruments to use in clinical trials. It's not an easy thing to do. I think most people, again, think that all you need to do is stick down a load of questions that seem relevant on a piece of paper and hey presto, you can measure something. That it's much more complex than that. And it's good that the EMA, the FDA have at last got round to recognizing that many of the sorts of outcomes that we need to know about in our clinical trials are things that are best reported by patients themselves, not clinicians. As you know, and I suspect many people listening know, the standard ways of collecting symptoms within a trial are to, and side effects are to actually use the CTCAE criteria. these really show very little concordance with the same questions that you give to patients. So for example, I was involved in some big studies when the aromatase inhibitors were being developed as hormone treatments for breast cancer. And one of the things that often affects adherence to long-term therapy are side effects, particularly vasomotor complaints. But if you looked at how many doctors and nurses recorded on their CRF, the case report forms in the trials, things like hot flushes or night sweats, it not only was the frequency, but also the severity of it was severely underestimated compared with that reported by patients on our questionnaires. So what's happening now in the US particularly is we've got something called pro-CTCAE. So certain side effects can only be assessed and measured by clinicians, but other things like pain or perhaps diarrhea or fatigue are best reported by patients themselves.
Mm-hmm. So let's move on to talk about communication skills and doctors, because I mentioned that I first met you in Dublin, and I absolutely remember as clear as day the film that you showed a bunch of urologists. It involved quite a young lady who'd been diagnosed with a gynecological cancer, and the surgeon had told her she needed to see a radiotherapist, but he didn't mention why. He didn't mention that she had a positive lymph node. And then when the oncologist told the patient, she became hysterical, and the oncologist looked terribly uncomfortable. You probably remember the film.
Yes.
Fantastic film. And it was all filmed so professionally. And then we all had to sit around and discuss, how rubbish we were at communications ourselves. So how did you get into that? And let's talk about how you make these films, because it was very professionally done. I remember that.
Well, thank you for saying that, and I'm glad that you still remember it. I think it was Jeffrey Tobias was the radiation oncologist who we filmed doing that. Okay, so one of the things, if we go back actually to that original trial I did in the very early 80s with Mike Baum, comparing mastectomy with lumpectomy. After that trial, we lots of people criticized it for all sorts of reasons, saying that the reason that we got sort of the results we did was because women hadn't chosen their treatment. They'd been randomized. And there was this notion that provided patients could choose, everything would be hunky-dory and they wouldn't have problems. So we did what we called the choice study. And what we found was that things like psychological morbidity had nothing to do with whether or not you were given choice. It had everything to do with the perceptions by the patients of the communication skills of the doctors. So those doctors who were good at communicating, good at explaining the rationale, the logic for why they recommend one treatment rather than another, had far less psychological morbidity in their patients than those who weren't as good. So I started thinking, well, we ought to do something about communication. And I think all of us have actually witnessed terrible communication, just as we've sometimes been the beneficiaries of great communication. And we interviewed lots of, I keep saying we, because I think, although the focus is on me this evening, everything has been a big team effort, and I'm so lucky to have worked with some wonderful researchers. We interview patients, we interview doctors, we look at real case histories, and then we find brilliant actors who are good at improvising from a role and a brief with real doctors. And none of our films that we make are ever scripted, because that way we get the doctors being much more realistic in terms of what they normally do. We just tell them, do what you normally do. Here are the case notes, this is the patient. And our actors, we've usually role played to death with them, virtually, the sorts of things that I know the doctors actually tend to say, or the phrases they use, and prompt them with a few questions. Then we film it. We use a great professional film crew, good lighting, good sound, good editors. And we get some great materials that are very valuable for healthcare professionals to discuss. And it's not just to say, oh, ain't he awful, or isn't she good? The important thing that we always do is get people to say what they would do differently. And that's where some learning comes. But sorry.
Actually, I'm just following on from that. Sorry to interrupt you, but Ros Meep says Lesley runs amazing courses on breaking bad news for nurses and consultants. She runs them creatively and with challenge, but does she think things have improved, or is there still room for improvement?
Well, thank you for that, Ros. There's always room for improvement, and even really great communicators can be helped with their colleagues to improve even further. We've focused on the films that I use, but one of the earliest demonstrations that we knew we could change communication skills came with a pivotal trial that we did that was published in the Lancet in the late 90s. And essentially we went to cancer centres, 34 cancer centres throughout the UK. We enrolled 168 different surgeons, oncologists and radiotherapists. And we went to their clinics and filmed the first 6 to 10 patients that agreed to be filmed. And we took all sorts of measures from the patients, from the doctors, as to how well they thought they'd done. We then actually randomized these 168 doctors to either getting comprehensive written feedback about their skills that we perceived from the videos, followed by coming on a 3-day course of just 4 people per group with an experienced facilitator, or people got their feedback at the same time as they came on one of these courses, or they just had feedback, written feedback, or they were control and had nothing. Then 3 months later, we went back into these clinics. It involved 5,000 patients in the end. We repeated all the filming again. And those who had been in control, or those who had been only randomized to having written feedback, were then permitted to come on a course. But the people who'd had a course, we then went back another 12 months later and 15 months later into their clinics, filmed them with real live patients again. And what was so gratifying, and I guess that's why the Lancet decided to publish it, was that we most definitely improved the skills of even some quite good doctors on the courses compared to those who only had written feedback, or those who were in the control group. And furthermore, these improvements were sustained and transferred into the clinic 3 months later, and then 15 months later. And as a result of that, we had real evidence to actually permit people to put money into doing these sorts of programs. The difficulty, though, is that on the actual 3-day courses, we were using very, very experienced actors, very, very experienced facilitators, and that's difficult to replicate and is quite costly. So that's why then my colleagues and I started doing things with trigger tapes and films more. And if anybody is interested, we've got lots of courses that hopefully as soon as this pandemic has really calmed down, we can start running again.
There are a couple of good questions coming through. There's one from Sarah Wooten. I know Sarah well. She works for dignity in dying, and she's very wonderful campaigner. And we may come on to assisted dying, which is one of the
Mm.
most interesting later. She says, does Lesley think that enhanced communication skills rather than aptitude at physics would make for better doctors?
Well, fortunately now you don't have to have A-level physics to sort of join a medical school. And indeed, my own son, who's a hepatologist, his A-level choices were English literature, maths with statistics, biology and chemistry. And when he was asked at interview why he'd done English literature, he told his interviewers that his mother, because by then I'd actually got a job teaching medical students at the London Hospital in health psychology. And he said, my mother marks essays from medical students, and the most frequent thing she says at the end of the essay is, traditionally, a sentence contains a subject, object, and a verb. You have many constructions with only two of these elements. So that's why he did English. And also I think that, and I think this is important and comes back to Sarah's sort of question in a way. I think having an eclectic range of things to draw on, to pull in when you're dealing with patients can be really important. You can often gain more about human emotions, about sociology, about sort of psychological dispositions from good art and literature and poetry than you ever can from a textbook about psychology. So I think sort of I'd always recommend that we sort of encourage our students to come from wider backgrounds. That said, you've got to have basic and fundamental chemistry, I think, if you're going to actually survive as a doctor.
One of the things I think I can't remember where I got it from, but I've written it in a few things, is that breaking bad news, if you get it right, people will always remember and be grateful for it. But if you get it wrong, they'll remember it in a very negative way. And Kate Hoyle, this is an interesting question. Thank you, Kate. What do you recommend about attitude during delivering bad news? I'm completely in favor of positive messages, but when my surgeon told me I had breast cancer, I found it slightly odd that he was so jolly about it. I mean, that's interesting, isn't it?
Oh gosh, that's a really, really important question. Yes, if body language and tone isn't right, whatever message you're giving is going to be sort of perceived by the patient in a variety of ways, and usually negative ones. Of course, one of the things that's always sort of quite interesting when you listen to very experienced doctors talking who've been around the block a long time, and let's say they are dealing with something like breast cancer. We know that breast cancer is many different diseases, and some of the features of the tumor are going to mean a pretty good outcome probably for the patient, compared with others who really have got very high risk tumors. And that's true not just in breast cancer, but in other cancers as well. Now, if you are dealing with these sorts of diseases all day long, from your point of view, the patient in front of you has got a reason to be happy because it could have been so much worse, but it isn't. But from her point of view, or his point of view, of course, that's the patient, they've got this life-threatening disease. So for goodness sake, in their world, this is a complete catastrophe. So adopting a posture of positivity without actually making it look as though you think this is a jolly good thing, I think is something that people do need help with recognizing. And that's why sometimes actually filming people with patients' permission, talking about different things that you can then unpick, does help sort of highlight some unfortunate turns of phrases or unfortunate body language that doesn't really work very well with a lot of patients.
What would be your top tips? I mean, you already mentioned attitude, and we were talking before about looking at the camera, which I'm not very good at. I'm working on it. I'm doing it right now. What sort of top tips would you give? Because I think we've got 630 people signed up for this. This is your chance to give them some key messages, Lesley.
What, when you're doing sort of remote consultations?
Yeah, because that's what's changed in the last year. Is you know,
Yeah, well,
it's so different not being in the room with and everybody says, oh, digital health, that's the future, but it isn't the same, is it?
it most definitely isn't the same, although I think that when we look at some of the surveys that have been done, many patients are actually saying that that's those who actually can cope with the technology have actually found it satisfactory. But I think really what they're responding to was that they were so scared silly that they weren't going to be seen at all. They're just grateful that somebody at least, could talk to them on the phone or talk to them via a video camera. The things that are important, though, when you are actually conducting a remote consultation, I suggest actually that people read an article I wrote that you actually encouraged me to do, called Enhancing Your Website Manner in Trends in Urology. It's not about urology, it's about, sort of this digital age and how we should be talking. There are lots of tips there, and I think one of them, first of all, is remember that you can become familiar with doing this, but patients aren't. So they're already going to be pretty anxious anyway, if you're talking about life-threatening disease or nasty procedures. So you've got to sort of recognize there's going to be an extra tension and layer of anxiety created just by, is this thing working? Certainly remembering to look at the camera is important, and that is problematic as well, because of course you're getting so many cues by looking at the person in front of you as to how they're receiving the news. So if you're giving particularly complex news, for example, you will miss, if you're looking at the camera, them sort of frowning or looking like they're not following you, or indeed sometimes distress if you're giving them difficult and sad news. So one of the things we know from some of the research studies that are coming in now is that you have to make probably explicit things that, if you were really face-to-face in the clinic with patients, would be implicit by the way that you looked at somebody, by the pauses, by the touching. Of course, our sort of broadband sort of service throughout the country is variable. You get hiccups and hesitations. You're not sure whether the pause is because somebody doesn't know how to construct an answer to your question, or whether it's something to do with the technology. So there's that. So I really recommend that people get somebody to phone ahead and check that the person really is comfortable with the equipment that they're using, that you are comfortable with your own equipment as well. That you don't take for granted that everybody has got, for example, the sorts of privacy settings that you really need when you're conducting interviews, particularly about intimate things. And if you've got your son who's good at computers, who's come and helped you sort of set everything up, it's not the time to then be talking about difficult things. So who's in the room? Who can hear things? Need to get that sort of clear. The other thing also that I think is sort of vitally important is that if there is a breakdown in communication in terms of, again, the technical issues are often the things that people are complaining about most of all, that there is a number to call that people can actually get through to you on, because again, surveys say that people are really cross when everything breaks down and there's nobody to call back. It is difficult, though. I mean, I know by default, Matt Hancock was suggesting that all GP visits should be conducted remotely. There'll be some advantages to that, I'm absolutely sure. But, you know, let's wait for the litigation when somebody misses something really serious because they couldn't conduct a clinical examination. And just to actually, you know, I've been on the other end of this during the lockdown, because I managed to rupture a popliteal cyst and tear my medial meniscus. And I have to tell you that a virtual remote consultation with an orthopedic surgeon about my knee, followed by a remote brace fitting, followed by remote physio, took fast to a level of absurdity that I really had to be seen to be believed. It was extraordinary. In fact, the orthopedic surgeon abandoned it in the end, and he said, "Stick a mask on," and saw me.
It can be a bit embarrassing. We have lots of female urologists these days, and they're absolutely brilliant. But virtual consultations with young men who've got spots in rather delicate areas with a young female urologist, it does raise interesting questions. I'm going to read out a couple of questions because they're so sweet to read. Irvin Benjamin says, "Great to see you. I was Mike Baum's successor in the chair at King's, and I took part of one of your courses on breaking bad news. A moving and unforgettable experience, and I've always tried to pass on your teaching to my own students and trainees. This is just a thank you." And
That's
then
lovely.
Nice question from Heather Sampson. Thank you, Heather. Two questions. Is there anything that you would have changed or done differently in your career? And what are your plans for the future? She says, "Thank you from Toronto. I teach medics as a researcher and research ethics chair. And this is a terrific talk," she says. So that's heartening.
It is heartening. Is there, oh gosh, you know, if you are a scientist, and we haven't really talked much about the research side of other things that my unit do, but I think if you're a scientist, there are always things that you might have done differently, you know, sort of, that's the joy and the desperation sometimes of good science. So there are some avenues that perhaps, you know, didn't actually turn out to be quite as useful as I might have hoped them to be. But you know, you learn all the time by mistakes as well as by things that sort of are successful. So would I have changed anything? I don't know, maybe I've been a better and more impactful psycho-oncologist than I would have been as a doctor. Who knows? But as far as the future is concerned, well, I suppose really, like you, Roger, I should have retired by now on one level, but I hope I'm surrounded by enough people who would tell me when they thought I'd really reached my sell-by date. Because at the moment, I still feel excited and enthusiastic by the work that we're doing. We've, during the pandemic, managed to carry on measuring quality of life in some really big national cancer trials with thousands of patients in who've been delighted that they've at least had contact with us. We've got lots of new projects on the go, in particular looking at the impact of many of the novel therapies that are now around. I mean, if you look at the transformation of therapeutics over the last decade, where a better understanding of the underlying molecular biology has led to the development of so many new treatments. And the problem is that things that excite the clinical scientist that might perhaps improve progression-free survival a little bit, or overall survival, perhaps rather modestly, that might be very exciting for you as a clinical scientist, but for the poor patient experiencing the side effects of those treatments, and everything that's new usually is low toxicity until it's actually used for a few years. We need to measure these properly, not so that we prevent these treatments entering the clinic, but so that when we've got an efficacious treatment that's been established via a clinical trial, we know what ameliorative interventions are needed to support the use of that treatment or that drug. So we've got a lot of work still to do on those sorts of areas, and we've got some new studies starting up looking at CDK4/6 inhibitors. We're doing some work also actually that relates back to remote consultations in a way, which is that there is a move afoot, isn't there, for patient self-management anyway. And my team have been busy interviewing patients who've been self-managing during COVID to see sort of how they've been coping and what the difficulties and problems are. So there's so much still to do. So I hope that I don't get a tap on the shoulder too soon yet from people who think it's time for me to go. But when I do, there's a lot of writing to do, and I still hope that I might be able to play golf.
Mike Baum actually is obviously watching this, and you'll be
Was
pleased.
he? Oh.
Yeah. I get criticised for being sort of, it's too much about chums, but I think that's part of the fun of these conversations actually. So Mike Baum says just a few words about how much fun we had together at King's in the 1980s, which is sweet. And then Deborah Allen makes a point really, which maybe I should have brought out. Are there any data on just how much bad news a layperson can actually absorb, given the shock of receiving it? I mean, I suppose that question is, the sort of mind goes blank, and perhaps we could talk a bit about the importance of having a patient advocate or somebody else in the room helping people absorb bad news. Any thoughts?
Yeah. Well, that's a difficult one because, I mean, all people are different, aren't they? And many patients, I guess, sort of who do receive a diagnosis, it's not that much of a surprise very often. By the time they've actually, especially if they're symptomatic, have experienced a problem, they've had all the different tests, done a few internet searches, talked to various people, they're probably coming along hoping against hope that they're not going to get a diagnosis of cancer. Some will deal with it with equanimity. Others, it will actually be, sort of devastating. And it's difficult to predict, sort of who is going to react in which way. I've met people who, have never amounted to much in their lives, never really said or done very much, who've actually faced, cancer with enormous resilience and resourcefulness. And I've met, captains of industry who've been totally devastated by the news. It's very difficult. I think really the only suggestion I have is that one does pace oneself when you're delivering difficult news. Probably the thing that what we often underestimate again is what is bad news to somebody, in front of you. Could it actually, from your point of view, be not too bad? We've already had that question earlier on, so we've got to think about that a bit more as well. At the end of the day, I think one just has to go with the person in front of you, be flexible, take time, make sure you give people a second chance to ask questions. And one of the studies that we did years and years ago that a lot of people now do routinely is we used to encourage patients to take away, in those days, a cassette tape of their interview. Lots of people, it's easy now, isn't it, on their phones to record. Encourage people, if they want to record the interview, because then they can play it back later.
And of course, the complexity of these consultations is getting more and more abstruse with cancer genetics. I know you're interested in particularly breast cancer genetics, because the bad news might not just be about you, but it might be your family as well, and your children and so on with the BRCA gene. I mean, any thoughts about how you transmit these things? We do have a section actually of cancer genetics at the RSM. We've got a wonderful Melita is in charge of that, and I think that kind of genetic counselling is very specialised, but also very difficult, isn't it?
Oh, it's extremely difficult, and one of the sadnesses about the pandemic is that my wonderful team and I had spent over a year developing a whole educational program called Trusting, which was talking about, genetics with a family. We interviewed lots and lots of patients and their families. We interviewed genetics counselors, geneticists, surgeons, and oncologists about their problems. And then out of all those interviews, we created a family with a varied history, sort of the old grandmother who had died of ovarian cancer, a father somewhere who'd got prostate cancer, and then the proband who actually had got breast cancer and had been tested and was found to carry a BRCA mutation. And the program includes all of our different family members talking to different people in their journey. And it includes, for example, a young woman who's related to the proband who, despite being tested and shown not to be a carrier, goes to see a surgeon demanding to have bilateral prophylactic mastectomy. And so we've got all these beautiful materials. We'd also worked out some very, very interesting exercises, some ways to evaluate whether or not it improved people's knowledge and their ability to talk to these very different family members. And we had fully subscribed courses, all booked all last year, that all got cancelled because of the pandemic. We're hoping to start those up again at the end of June. So anybody who's listening to this who's interested, it focuses primarily on somebody who's a BRCA carrier, but of course it's relevant for gynecologists and urologists with prostate cancer because they're all involved, although we focus mainly on the breast. If you're interested, please look on our website, our Shawsey website, and you can see details of emerging in the next week about where we'll be running courses. And if we show that these programs are successful, Roger, I'd love to give them to the RSM to run them, because we make these things, we never sell them, they're for wide use with whoever actually can utilize them. But we like, as Mike Baum always told me, always have your data. We only like to release these things when we've actually got evidence that they actually work and improve things.
Are you really a frustrated film director, Lesley?
Yeah, I'm wanting your daughter to come and act in one of my movies. Yes, I love making films. I mean, because, I told you that sort of if I retire, I'll probably, write and do things like that. And I'm a drama queen. Come on, let's admit it. The thing I've hated about lockdown has been I've so missed the smell of the grease paint and the roar of the crowd. I mean, we are all performers, aren't we? If we're researchers who go off and give talks at conferences and everything, we're performers as well. So we know all about working a crowd with, sort of whatever it is you're talking about. And that's enjoyable. I am deadly serious about our research. I'm deadly serious about the impact that this horrible, horrible disease has on people. But I do feel that there is a role for us all working in this area to also have some fun and enjoyment when we're working so hard on all these different things.
I was reading about poor Helen McCrory, died from, I think it was lung cancer or something. It was definitely a respiratory. illness I think she had. It doesn't say in the newspapers, but it uses, of course, the media always come out with Helen has lost her battle against cancer. I mean, do you think that is a good analogy? Is it a battle?
No, I think these sort of wartime analogies are hateful. And indeed, the deputy director of my research team, Professor Val Jenkins, recently had an article from Sussex News that got quite a lot of traction on Twitter about, it's time that we really stopped this, fight with cancer. Because the implication, of course, if you lose the fight, is that, you had a chance of beating it in some way, and that isn't so for a lot of patients. They're very brave and stoical in the way perhaps they accept what happens to them, but to suggest that all you've got to do to beat this thing is just fight on bravely. When I used to commute up to London from Brighton, where I live, I commuted up to London for over 20 years. I used to sit on the train journeys, inventing titles of articles that, I probably would never write, and no one would ever publish. And one was, what about the wimps? And what I meant by that was, I'm quite sure that if somebody told me I had cancer, I would cry. I certainly wouldn't feel inspired to abseil down the side of the Lloyd's building or run a marathon to raise loads of money in my fight for things. I'd probably be really, really upset. And do you know something? It's all right for people to not feel brave, to not feel that they are going to fight this. They have to accept the fact that they've got a disease, that the people, and trust that the people looking after them will do everything they possibly can to get them the best evidence-based treatment for it. But to keep people fighting, particularly for an implausible outcome, I think is plain cruel, and we should stop it. We should really stop it.
We're running out of time, and wow, this hour's gone so quickly. But actually, Linda's come up with a question I was going to ask anyway, which was, what achievement are you most proud of? Could it be that Damehood that came through in 2016, or maybe those two lovely children of yours?
I was going to say, I'd probably actually say my achievement is a personal one, which is actually having got two great kids, four lovely grandchildren who all forgive me for being a rather unusual sort of mother and a rather unusual sort of grandmother. They're my worst critics, tease me unmercifully, and I miss them all dreadfully, during this horrid pandemic. The Damehood was an amazing sort of experience, but I felt it was a privilege to accept it on behalf of not only, sort of the many, many sorts of wonderful researchers I've actually worked with, who have developed this field of psycho-oncology. I mean, it's recognized as a subspecialty of oncology now, and it certainly wasn't in those days, early days of the 80s when I first went to work with Mike. It was awarded for services to psycho-oncology, and I thought that really put it well and truly on the map, and was a testament, I think, to not only all the amazing researchers, as I said, that I've worked with, but those incredible patients and their families who've given so much to help us with our research. And indeed, when it was announced, one of the things that actually made me tearful was I got lots of letters. And how many people write handwritten letters these days? Not just a text message or an email, handwritten letters and cards from patients or some of their relatives who remembered being in some of our old studies 20, 30 years ago, saying how much their mother, father had valued being a part of the research enterprise. So yes, I was proud. I'm allowed to feel proud, I guess, but I think it was because you know, it really brought up so many good feelings about the good people that there are around that are willing to join in trials, number one, and the good doctors and nurses, healthcare professionals who are prepared to actually to admit that they perhaps could do something about their communication skills and come on a course, sometimes for 3 days, with a smarty pants psychologist who can help them hopefully find different ways of talking about sad, bad and plain difficult things.
Well, I think there must be thousands of doctors, including me and including Mike Baum and many, many others who are grateful to you, because definitely listening to your course helped me communicate with my patients after that. And don't go away, Leslie. I've got a few announcements. I always have to make some announcements at the end of this. Thank you so much for a brilliant talk. Tomorrow we have Henrietta Bowden-Jones, our wonderful member of the RSM and head of the psychiatry section. She's talking about mental health during the pandemic. That's at 12:30. Next Tuesday, very important, we've got the fourth of our climate change webinars. This is on hazardous temperatures and cardiac health. That's next Tuesday in the evening at 6 o'clock. And next week, our In Conversation, we've got our immediate past president, the amazing Simon Wesley, talking to Harry Brunjes and Nika Burns about the ENO and NIMAX theatres during the pandemic, which have been, of course, badly affected in London. That'll be we're filming that actually in the RSM for the first of these series. So do join us for those. Leslie, it's been really, really wonderful to be taught by you and to talk to you tonight. And I'm sorry we didn't get through all 35 questions, which I can see have logged on here, but I think we've got through quite a few of them. So we'll see you next week, everybody. Leslie, thank you so much. Have a wonderful evening. You can go and have a glass of wine now. We'll allow you to do that. Bye.
My pleasure. Bye-bye.